Hi, my name is Brian Varula. This is my video presentation over distributive shock. This is the third video of my video presentation project. So, what is distributive shock? It results from an excessive vasodilation and the impaired distribution of blood flow. So, septic shock is the most common form of distributive shock, and it is characterized by considerable mortality. It is treated in around 30%, is untreated, probably greater than 80%. In the United States, this is the leading cause of non-cardiac death in the intensive care units. Other causes of distributive shock include systemic inflammatory response syndrome, which is due to a non-infectious inflammatory condition such as pancreatitis, toxic shock syndrome, anaphylaxis, reaction to drugs, and that's also including insect bites, transfusion reactions, and heavy metal poisoning, hepatic insufficiencies, and neurogenic shock due to brain or spinal cord injuries. So distributive shock, we're going to talk about systemic inflammatory response syndrome. It is the presence of at least two of the following four criteria. So if the person or patient has a core temperature of higher than 38 Celsius, or that is greater to 100 degrees Fahrenheit, or lower than 36 Celsius, which is 96.8 Fahrenheit. They can also have a heart rate of more than 90 beats per minute, respiratory rate of more than 20 breaths per minute, or arterial carbon dioxide tension less than 32 millimeters per mercury, a white blood cell count of more than 12,000, less than 4,000, or more than 10% of immature band forms, which is all found through a complete blood count. So the pathophysiology of the type of shock that we're discussing today is and how does our body react. We want to first note that the inadequate tissue perfusion is caused by the loss of the normal responses of vascular smooth muscle to vasoconstrictive agents coupled with a direct vasodilating effect. Thus, the fluid resuscitated patient is a hyperdynamic, hypertensive state associated with increased mixed venous O2 saturation. However, the tissue ischemia is manifested by an increased serum lactate. Shock would be a warm or hyperdynamic, which causes a reduction in diastolic blood pressure, widening the pulse pressure, creating a flushed, warm extremities, a brisk capillary refill, from peripheral vasodilation with a compensatory increase in cardiac output. But in the late septic shock, the patient is very cold or hypodynamic. This is where myocardial contractility combines with peripheral vascular paralysis to induce a pressure-dependent reduction in organ perfusion. This disrupts the coagulation cascade and can result in a slower activation time. During disruptive shock, patients are at risk for diverse organ system dysfunction or organ failure. Mortality from severe sepsis increases markedly with the duration of sepsis and the number of organ failing. To dive a little bit further into how our body reacts, there are different types of ways we can develop into this type of shock. So a decrease in our systematic vascular resistance is due primarily to massive histamine releases from mast cells, or this is basically your allergic reaction. After the activation by these antigen-bound immunoglobulins E, there's an increase in synthesis and release of prostaglandins. Other patients with shock frequently present with tachycardia, tachypnea, hypotension, altered mental status stages, and oliguria. many prior symptoms that suggest infection or inflammation to the respiratory tract, urinary tract, or abdominal cavity. You have, presence of pneumonia, and for that, it will be hearing a dullness to percussion, bronchi, crackles, bronchial breath sounds. For urinary tract infection, costovertebral angles or tenderness, and dysuria and polyuria. These are just symptoms that we will note. Intra-abdominal infections or acute abdominal are focal or diffuse tenderness to palpation, diminished or absent bowel sounds, and rebound tenderness. Pancreatitis may be another cause of disruptive shock. It can expect symptoms of abdominal pain that radiate to the back, as well as nausea and vomiting. That's one of the main ones too. Burns also have been described as a cause of disruptive shock. Adrenal insufficiencies also cause a shock. Should be considered in any patient with hypotension who lacks any signs of infection, cardiovascular disease, or hypovolemia. So in generalization, physical examination of our patients that come in, we will see a change in mental status. This is due to the poor perfusion and ventilation that they are receiving, heart rate greater than 90 beats per minute. They might seem hypotensive, systolic pressures of less than 90, and a reduction of 40 from baseline. Respiratory rate greater than 20 breaths per minute, or just tachypnea. Extremities can be frequently warm with bounding pulses, but it increases in blood pressures. But that's only in the early shock stage. The late shock stage can present as critical organ dysfunction. Hypothermia, core body temperature of greater than 101 Fahrenheit, or hypothermia less than 96.8 Fahrenheit. Pulse oximetry, it's relative hypoxemia, or less than 88% of saturation, or a decrease in urine output as well. Now we'll be going over imaging studies that aid in the diagnosis of, that's not supposed to be hypothermic, it's disruptive shock. So one of the primary imaging studies used to aid in the diagnosis of this shock would be a point-of-care ultrasound, particularly focused on the echocardiograph, which allows for real-time assessment of the cardiac function, the fluid status, and can help differentiate between different types of shocks, including disruptive shock, by evaluating parameters like cardiac output and the inferior vena cava size. Echocardiograms as well, the ultrasounds as well, chest x-rays, and CT scans. And here we have a few. These pulmonary infiltrates could be pneumonia. We see a disruption here because we have a rupture in the left ventricle to the in the heart, and then here as well. Here's a CT scan, and this is actually a lung ultrasound. So we're seeing these abnormalities here, thick mucosal membranes, just prevalent in the spaces in the lungs. So all patients with evidence of this shock would undergo the following studies. So the patient would get a CPC with differentials, urinalysis, electrolytes, albumin levels, creatinine, glucose, urine cultures, blood cultures, and as well as sputum cultures. They will also get ABGs and at least venous blood gases, just to see if we're oxygenating or we're retaining. Everything else is usually just for if we're losing enough, if we have enough electrolytes, or if there's any chances of a positive bacterial, viral, or fungal infection that could be present. So monitoring techniques and the values relevant to the shock. All patients should be admitted to the ICU. Vital signs, fluid intake, and output should be measured on an hourly basis. Daily weights should be obtained and adequate intravascular access should be secured. Again, these are mostly things that the nurses or doctors would do, but a central venous access should be considered. Those patients should have an indwelling urinary catheter. Oxygen should be administered immediately by mass, that's a given. In patients with altered mental status or respiratory distress, severe hypertension, elective endotracheal intubation, and mechanical ventilation should be considered. We try to avoid emergent intubations in the event of subsequent respiratory arrest. So we want to get it beforehand or before the bad stuff has started to happen. Mechanical ventilation can also aid in the hemodynamic stabilization and decreasing the demands posed on the respiratory muscles or on circulatory as well. Pharmacologic options and medications that can improve the condition and restore homeostasis. So these will be your antimicrobial regimens. Again, these are things that are going to be targeting directly towards the viral infections or the bacterial infections to decrease the risk of super infections to resistant organisms. That's the last thing we want to happen. Or give hydrocortisones only to hypertensive patients who are poorly responsive to fluid resuscitation and vasopressors. So hydrocortisone would be the steroid of choice for that. Systemic vasopressors is indicated in patients with hypotension due to sustained septic shock. And again, to do not reverse the hypotensive with the fluid therapy. This shows here the more of a full list of medications that it's too much to get through. ABG anomalies you will see in disruptive shock would be a mild respiratory alkalosis due to hyperventilation. It's often accompanied by a normal or slightly elevated PO2 and a low PaCO2, reflecting the increased respiratory rate seen in these type of shocks. Because the patient's breathing heavily, it's because of either fever, whatever is going inside the body, respiratory alkalosis, most common, rapid breathing, a normal slightly elevated PO2 since the lungs are generally functioning well in this type of shock, and low PCAO2, of course, due to the hyperventilation. Mechanical ventilation options, you have a high flow nasal oxygen therapy for non-invasive ventilations, usually for sepsis-induced hypoxemic respiratory failure, or patients that have already ARDS or developed this. This would be kind of like the guidelines of what we want it to be. We'll just follow that ARDSNet protocol and prone positioning. This is recommended in adults with sepsis-induced ARDS for more than 12 hours a day. This could help with oxygenation and ventilation. Intermediate neuromuscular blocking agents. You don't want this patient moving around, fussing around, and they're going to be in a lot of pain. This is something that we have to get through. And at the end of the day, last treatment would be ECMO, and this has actually been used in experienced centers, or it's only used in experienced centers. This here is my reference page. These are all the references I use to include my information. But for a quick summary, we learned about distributive shock and how there's two different kinds. We have a septic shock, sepsis shock, or a inflammatory response shock. For sepsis, there are two types as well, early and late, both being drastically different in the way it clinically presents itself, along with inflammatory responses. You will see an anaphylactic response. So we talked about the different clinical imaging diagnosis that could help diagnose the different types of distributive shocks, such as lung ultrasounds, CT scans, chest x-rays, and things of that nature as well, and how different types of antibiotic therapy could help, as well as the mechanical ventilation as well. That seems mostly what you would want to work towards to help stabilize the dynamics the hemodynamics. I mean, thank you for the thank you.